So now let's hear from Dr. Srinath. I'll invite him, who will tell you about SURPASS 2 and comparison of Tirzepatide head-on with other GLP-1 analogs in people with diabetes also, along with people with obesity. Dr. Srinath.
Good afternoon, everyone. At the outset, I'd like to thank Ganesh ENDODIABCON 2025 and also Lily for sponsoring me this talk. So, Dr. Praveen has highlighted everything about the SURMOUNT trial. I think the correction mine is initiating Tirzepatide, Dr. Ashok. And we can then definitely we can talk about SURPASS if you are okay.
Please.
Yeah, thank you. So I think we all, I don't want to be the nuisance between the lunch and this talk, but I think from morning you must have heard a lot about the obesity medications, the semaglutide from Dr. Santosh. Now we have heard about Tirzepatide by Dr. Praveen. So all is well said, but what I am thinking is when we are initiating these high-end molecules, the discussion, the first discussion between the patient and the professionals should be robust. That means we need to spend more time. Patient need to understand what is, as Dr. Ashu has told, diabetes is a disease. ABCD is adiposity-based chronic disease, which we have known that. People do not recognize that as a problem unless until it gives a symptom. So now obesity is going to be a serious concern for everyone in our day-to-day practice, because most of the patients who are turning to us with diabetes, hypertension or any chronic comorbidity have obesity. So if you are able to talk to have a dialogue between the patient with the patient about the management of these obesity with these molecules, the patient should have an understanding. Like many questions, like Dr. Santosh did mention about the discontinuation of these molecules so in shorter or intermediate duration is very high. That means patients will come out of these molecules probably because of the cost, or I'm sure because they may feel that they have lost enough weight. And clearly SURMOUNT 4 clearly showed that after discontinuation what happened, Dr. Praveen has highlighted that. So which means initiating Tirzepatide in patients with diabetes and patients with obesity. Now, we doctors are not great when we are talking about a practical initiation of a molecule. It's wonderful. We have knowledge, we have the delivery, how we can talk to the patient, but when we are practically demonstrating or practically talking about it, we are probably for a little bit lesser compared to other parties. So, what are the other parties like diabetic specialist nurse or somebody who injects? For example, I'll just tell you, recently, a year ago, I did a practical insulin delivery in Bangalore. And I invited around 100 doctors to that delivery talk. And to my surprise, and not surprisingly if you do it again, only 20% of the doctors actually knew how to inject an insulin, how to change the cartridge. So, when we are talking about these molecules also, we need to know how these molecules are actually presented, how we can initiate it, and how to continue so that a patient doesn't fall out on it. We have seen patients losing the molecule, wrongly injecting, or even they have faltered, the medicine has been lost without delivery also. So that means we have to practically, the first injection should be done in front of a clinician if you want to be successful. Otherwise, patients are doing it their own way, and it's probably the education is not reached. That's what that is the most essence of my talk. So if you talk about Mounjaro, how it is developed, so it is as clearly Dr. Praveen has highlighted, it comes in 2.5, 5 mg at the moment. We know about the trials talking about 7.5, 10, 12.5, 15 in the Western world. At this point of time, we are limited only to up to 5 milligrams. So it's very clear that we initiate 2.5 at the starting dose. Now, before initiating, in my practice, what I have learned in the last 6 months or so is, when I am initiating, as Dr. Praveen has highlighted about the side effects, talk to them after you talk about the benefits which he has clearly mentioned. Now, if you are addressing the side effects, it's better even to prescribe and mention like how we do for the SGLT2 inhibitors, warning about the monilial infection. We even prescribe an antifungal cream or medication if required. Same thing with these molecules. You don't want them to come within 48 hours to an emergency because they had a very bad intract vomiting or loose motions or abdominal pain. It's better that they are aware of this and to do first aid, what to do. So I even have prescribed antiemetic, antidiarrheal and also antispasmodic. So it helps. That means we are communicating to the patient and they are able to understand that they don't need to rush and come to an emergency or seek for help. So escalation is very clean. Now Manjaro is available in vial. If you see all the internet-based patient information sort of messages, what they get on the websites, it's all pen delivery, that's what it talks about. But at the moment, we have vial in India. So it comes as a 0.5 ml vial, whether it's 2.25 or 2.5 or 5 milligrams, it comes in a vial. And that has to be injected 2.5, maintained for 4 milligrams, that's what the manufacturing says. In my practice now, I've taken a little bit longer, so even 6 weeks, because people are having a lot of side effects. We do not know how the molecule behaves in an individual basis. Yes, we need to move on to 5 milligrams at the early, whatever has been prescribed, 4 milligrams up to, so then move on to 5 milligrams, which is where we are probably continuing at this point of time. But probably going up, increasing it should be in a rather a slow fashion. That's what you need to do. And it's very important, whether it is diabetic or in obesity, the dose is the same and the titration is also remains the same. So that means you need to see the first dose, ensure that they take it in front of you and one of you or your diabetic specialist or whoever is their educator delivers in front of you. That will be the best way, the outcome, because we have lost it. So one patient 2.5 tried to inject, it went off. So we lost the amount, that amount of the molecule. So it is how we explain to them how to take it, where abdomen or the legs or the shoulders, whatever. These are the websites which are there. And I have gone through individually about this patient information leaflet. It all talks about the pen, which probably soon I think the manufacturers will bring it back to India, will bring it to India as well. But it is now clearly an obesity, as Dr. Praveen said, we have nothing. Orlistat does nothing, to be honest. It just, patient comes after 4 to 3 months. If they don't lose 5% of their body weight, it's absolutely waste to continue. So that means what is the other molecule? As nothing else is we have for obesity. Now SEMA has been licensed at 2.4. Yes, that's a different ball game. But we have 2 molecules in one coming, and that is what licensed for obesity and non-diabetic also. So that is the most important. And there is a lot of information we can get, and at the moment it's the vial. So what happens when patients, say for example, we are dealing with diabetic populations. So number of things go around. They may be on metformin, they may be on sulfonylurea, they may be on a pioglitazone or SGLT2 inhibitors or DPP4 inhibitors or insulin. What happens? Rule number 1 is ensure that the DPP4 inhibitors are taken out. There are some studies which have said use of dual GLP1 and DPP4 inhibitors use, but probably it's wiser to stop the DPP4 inhibitors, number 1, and start this. Because we know that once a patient is on a DPP4 inhibitor, the GI side effects, they have been okay, but not necessarily if GLP1 and GIP can still cause GI side effects. So taking number 1 as a DPP4 inhibitor is the most important. Continuing metformin and SGLT2 inhibitors is no harm. As somebody spoke earlier that DPP4, the GLP1, Santosh I think, GLP1 with the SGLT2 inhibitors is perfectly fine to continue. You will get the synergistic effect. Now the problem with sulfonylurea, we know it's a weight, in secretagogues, they do weight, and insulin being an anabolic hormone, it tends to gain weight. So the dose has to be reduced, because the hypoglycemic effect, what we are seeing is mainly coming from, not from the GLP1 or the GIP, but because of these molecules. And we all know the gut peptides are released only when we have a meal. That is why I think the importance about the CGM today, I'll just share a very important information about a meal. So what happens now after we all finish our session, go for a lunch? Now, for example, what is palatable and what is non-palatable? Suppose you fancy food which is really tasty. The problem is they are absorbed very quickly in the gut, By the time it reaches your intestine, it's gone past very fast. So your L cells or whatever in the intestine are not able to produce the effective GLP-1 or GIP. This is the problem. That is why we are trying to tell people to eat food that is absorbed slow, and so that by the time the food reaches your intestine, the L cells producing the GLP-1 will be robust at the activity. So that is where these molecules come into practice, when we can't have and control on the satiety. So this is one which comes as reduction in your absorption and also the satiety, and clearly working at the brain level, at the paralimbic and also the hypothalamic level. So the important thing is metformin is okay, SGLT2 inhibitor is okay, other molecules we need to reduce it. And I think children, we are not licensed. We had a wonderful talk from CMC obesity metabolic team in Bangalore, I think 3 months ago in our Karnataka endocrine update. They have started these molecules as early as 13 years. If you have childhood obesity, they are still working on it. It's not licensed, but anecdotal they have been reported. But as of now, 18 years is the cutoff. And the important thing practically I actually faced was in a renal failure. I had a CKD5 known hypertensive transplant due for a transplant, and the nephrologist referred to me for this molecule. Now, how many of us are confident to use this molecule in an obesity in stage 5? The data is not there. So I had to tell them that, sorry, at 5, we are not licensed, we are not doing it. 3B maybe is the last. So in advanced CKD, please don't use this molecule in obesity. And of course, in hepatic impairment also, we are not in the longest form. Although we have the NAFLD, NASH data, even in early cirrhotic also you can probably, but advanced you are not using. And of course, pregnancy and lactation, we do not. And they recommend not to become pregnant at least after stopping 4 weeks, because the molecule tend to remain in the system. So 4 weeks after stopping is when you can ask them, the couple, to conceive, plan to conceive. So these are the important education that we are talking about when we want our molecule to be more effective, in addition to the mentioning to the adverse side effects. So the most important is eating smaller meals. That's what we advise our pregnancy patients, isn't it? So you have 7 or 8 even meals as a small go, if you really want to. You don't want to have a very high spike in the sugars. The same thing, eat smaller molecules is very important, and you need to know what you are eating. That's very important. And the dictum is, please don't eat when you are not hungry. That's what we need to tell, and that's what we need to follow as well, because there's no point when you are full now, no point in having a lunch. Of course, if you really need to, if it is your regular pattern, that's okay. But if you're not hungry, I think that is what the message you need to be passing on to our patients as well. And staying hydrated. I don't know what happens to the spicy food. We'll have a discussion about that. And about alcohol or fizzy drugs, fizzy drinks, one has to be extremely cautious. And this is about pancreatitis and the thyroid cancer. People do ask in majority of their talks. There is an interesting paper which has come out also, that GLP-1 and GIP or even DPP-4 inhibitors do not provoke a pancreatitis. So if people on these molecules having a pancreatitis is probably very limited, but it is very clear that we are not using these molecules in someone who has a past history of pancreatitis. That is very clear. So we don't want to deal with fire. So we ask the history of any pancreatic cancer. At the same time, we do not want to go on doing ultrasound scans on people for thyroid nodules. That's not on. So clever way is to just a checklist to ask whether they had a history of pancreatitis and move on. If it is MEN related, we are not bothered at this point of time. We don't do a general routine screen for thyroid cancers also. And I did mention about the pancreas, the pregnancy and the lactation. It's a no-no. So what happens if a patient misses tirzepatide? So suppose he is taking on a Thursday morning every week, and he fails to take the Thursday for some reason. Thursday, Friday, Saturday, he can wait. Whenever he remembers, he can still take. By the time he's gone to Sunday, that means 4 days passed, he goes back to his Thursday cycle. So as simple as that, first 3 days or 72 hours is okay for them. As soon as they remember, they can take. But beyond that, it's better to just go on to the cycle day where he was scheduled to. That is the best way to give them a practical way of explaining to the patients, because they are bound to miss somewhere or other because of other schedules. So I think I come to end of my talk. I'll now hand over to Dr. Ashur and we'll have a Q&A session. Thank you.
Please join here. So we'll take some questions from the crowd. So if I summarize both of these things, one thing is sure, that this is a drug that will change how do we see this condition. Now we call our disease, that is obesity. And now it is approved for chronic weight management in patients with BMI more than 27 with comorbidities. Remember, 27 is now the DCGI update about the weight management with tirzepatide with any comorbidity, which can be hypertension, dyslipidemia, diabetes, and whatever. So, any questions from the gathering, please? We can take questions. And till somebody stands up and asks questions, just for discussion's sake, Dr. Praveen. So, in DM days, whenever we used to learn, we used to be taught by our teachers that we have a lot of GIP resistance, and it is the GLP which is main incretin that is responsible for insulin secretion from pancreas. Now, how do you see a dual agonism with both GIP as well as GLP-1 separate from GLP-1 agonism? Though you have mentioned, but you can just tell the crowd in crux 2-3 points, dual agonism versus isolated GLP-1 agonism.
Yes, sir. So, initially what GLP-1 was thought to be the stronger one, but in reality, GIP is twice as prominent in secreting insulin when compared with GLP. And especially this test was done with oral glucose tolerance, where 44% was contributed by GIP, whereas 22 by glucose and GLP. When mixed meal test was tried, it showed nearly 66% increased secretion of insulin was contributed by GIP. So this clearly states that the GIP stands out along with GLP, and both put together definitely gives the upper hand in improving the insulin secretion. And also when given supraphysiologically, this combination not just increases significantly the insulin secretion, but also reduces the glucagon secretion.
Yeah, thank you. So, Dr. Srinath nicely mentioned about that there are very specific so-called absolute contraindication for use of tirzepatide, like in a patient who has recent history of pancreatitis, or a patient who is having medullary thyroid cancer, or a patient who is having MEN. So these are uncommon situations. Otherwise, this tirzepatide is quite a safe molecule. So just for discussion, Dr. Srinath, we want to ask that is it advisable to do at least liver function test before tirzepatide? And if we do liver function test, is there any headwind, like if LFTs or OTPTs are more than this, probably you will not use tirzepatide, or it's quite safe despite having 5 times or 8 times or 10 times OTPT increase?
Yeah, thank you, Dr. Ashu. I think we all know about the GLP-1, its effect on the fatty liver disease or NAFLD. So the best way is to have a sort of protocol, metabolic screen before you are before you are using this molecule. So the most commonly is the SGOT, SGPT, we do check them. What happens if it is normal? Normal is still beneficial because that is still not a marker for a fatty liver disease, we know that. Say for example, if you have a 2 times to 3 times raised AST or ALT, that is a perfect setting for this patient because we are now dealing with a metabolic liver disease. In this situation, using this as a marker on this molecule, you can follow up and see what could happen in addition to the ultrasound imaging, because we are doing a study on the fatty liver disease on this, not with the GLP-1 or GIP, but as a marker to see what happens to these population, both on the imaging and also the biochemistry. Now, if you're talking about the 10 times of coming of the liver function test, this is a situation where we may be dealing with a very serious inflammatory disease. At this point of time, before we start, I think we need to ensure that it is not something, an acute event, before we jump in and start this. So, taking probably a gastro opinion or looking at history, what is happening, what is the history of this, is this a population who, did he have it for a longer duration or something acute happened, symptoms of fever, abdominal pain, I would take it that way, and also a referral to gastro would be better, because now what is happening, the gastroenterologists are now referring to us, or we are working as a team to ensure this molecule is effective, especially in the Nafaldo-NASH. That's how I can put it.
Yeah. Thank you, thank you. Otherwise, the label indication says that it's quite safe in patients with chronic liver disease.
Yeah.
Though it has not been studied in patients with maybe Child-Pugh C or Child-Pugh B,
Yeah.
but at least we need to do OTPTs in all our patients, and as you rightly mentioned. So any question, again I am inviting any questions, because time is up. So any questions are there? Dr. Ganesh, we can take during the lunch time. Okay. Yes, sir, please.
Time of the day for injections or food intake?
Perfect. So the question is related to what should be the time of the day where Tirzepatide should be offered to our patients. Dr. Praveen, Dr. Srinath, will you like to take it?
I mean, there is no problem. It can be taken anything. Unlike there are some GLP-1s which has to be given first thing in the morning or so. It's usually for practice we advise them to take it in the morning, so it is effective throughout the day. There is actually no indication whenever they can take. Even if patient has missed it in the morning, he can, if he remembers, he can take it in the afternoon. So there is no major circadian sort of we have found out. So it is effective to the best of my knowledge.
Since it's a longer duration acting molecule, it can be taken any point of day, but the instruction should be clear that after taking the injection, the patient should follow restricted fatty food or avoiding the spices food, and also make sure the patient hydrates well, sir.
So the message is, Dr. Mahesh, I'll just summarize the answer to this. The message is that it can be taken any time of the day, even in the trials that have been given, but it should be consistent. If the patient is more comfortable taking in evening, that's okay. It doesn't matter. Yes, please.
So I think it was an excellent talk. The most common side effect that we are noticing is actually diarrhea in dual agonist, and actually nausea and vomiting in the isolated one. So is it possible to, like, if the patient is not responding to one, can we shift to the other isolated GLP-1, or is it mentioned anywhere there is somebody has used this, then has not responded or having side effects, you can shift to GLP-1, or either vice versa? Can you shift from single to dual or dual to single?
I have an experience. I don't know whether I'll be able to answer to your point, Dr. Mahesh, but I have someone who moved from GLP-1 injectable to the combination of Manjaro, because number one, there was no concern about side effects there. Initially, they had a problem with GLP-1, and this is the injectable sema at a very high dose, and mild GI side effects were there. It was mainly the nausea and vomiting. Nausea mainly. And when they moved on to the combination of this molecule, he's got used to that symptoms. So again, in this situation, this patient was on a prolonged pantoprazole, which is what is it called? Proton pump inhibitors. That's what he was on for a longer duration. So I do not know whether that also can help in this set of population. Whether it will mask the effect, I do not know.
So to answer Dr. Mahesh's question, so we have evidences from SURMOUNT 4, 5 and even SURPASS 2. And Dr. Praveen also showed that the incidence of nausea, vomiting, diarrhea was similar between semaglutide and tirzepatide. You can pick and choose, but it does not matter. If you're expecting that one drug is causing nausea and you switch on to another drug, it will lead to reduction in the nausea. It doesn't happen. So these trials have not shown that switching between GLP-1 analogs will reduce the incidence of side effect. It does not matter. It is very individualistic. Some patients do not develop nausea at all, and some patients do develop. So it is the overall effect of incretin analogs rather than switching between two drugs.
Thank you, sir. Thank you.
So let's wind up this session, because I'm really fearsome of Dr. Ganesh. He is telling, let's have lunch. Okay, thank you.